allocated into the allocation, and it can literally be anything you want it to be. From board games to karaoke to playing piano together to going for a jog in the garden, which I won't get onto how much of an issue that became with one of the medics, but anyways, apparently everyone needed assessing first. I was like, I'm not sure why. He was convinced someone was going to have a heart attack and die. But this is what unstructured activity is. It serves two purposes. Firstly, it alleviates boredom. Because when people are bored, they think, and when you think too much and your life is really, really at its low moments, guess what? You start to think about doing really bad things. Yeah. Or to others. That's the other thing with boredom, and anyone that's worked PQ will know this. A bunch of really, really psychotic, normally aggressive people who are bored tend to not be too pleasant to each other. And you end up with this. The other thing about boredom is that it also sends a message that then we don't care about it. Because we're not doing anything. And what I would say about rewards, and this is a really important thing for you to think about, what I would ask you is this. Go back to your boards and just spend 10 minutes having a look at what is the general offer of therapeutic interventions on this board. Just go in there. And I know you're all thinking and going, oh God, it's not a lot. And it isn't. And that is where the vast majority of our problems come from. Because if we do not have a general offer of therapeutic care, how can we have an enhanced level of care? One does not exist without the other. And I'm assuming some of your wards are involved in culture of care?
Yeah.
I'm guessing your self-assessments were lovely and green.
Oh, I don't know.
I don't know, but we can find out.
Yeah.
If they are, redo it. Because if you're saying they're green, even though you know on that ward you cannot define the general offer of therapeutic care, they're not green. And it's look, everyone thinks we're doing the right thing up until someone shows them maybe we're not. And our staff truly believe that what they're doing is right because our organisation has told them what they're doing is right. So why would they think otherwise? And these are the things we need to change.
Mental health is finally getting the attention it deserves. For too long, it's been shrouded in stigma and misunderstanding, but things are changing. The NHS, the UK's public healthcare system, is stepping up its game with a renewed focus on mental well-being. At the heart of this transformation is a commitment to enhanced engagement and zonal care within inpatient mental health units. What does this mean? It means creating a more compassionate and effective system of care. Enhanced engagement is about truly connecting with patients. It's about listening to their unique needs and experiences. It's about empowering them to take an active role in their recovery. Zonal care takes this a step further by dividing inpatient units into distinct zones, each tailored to a specific stage of recovery. This allows staff to provide more focused and personalized support. Imagine a place where you feel heard, understood and respected, even during your darkest moments. This is the vision behind enhanced engagement and zonal care.
So, moving on that cheery note. So, yes.
Can I ask a question?
Yes.
Or do you want me to wait?
No, go for it.
So I'm sitting here now, so we've got on the wall here, the word observation is banned. Yeah. So now I'm thinking, God, we didn't go far enough. Observation is banned, right? But I'm just curious from a strategic, from our sort of, we lean into our leaders. I'm just wondering why our leaders aren't saying to us explicitly, do not observe patients. The same way they said explicitly many years ago, stop using phone restraint. I'm just curious about that.
So mainly there is no national guidance to give them the backing they need to make that decision.
Right.
And that is problematic because if a patient completes suicide on your ward,
Yeah.
and we go to a coroner's and we have fundamentally changed the way we approach care on our ward without the backing of national guidance,
Yeah.
they are going to haul in that chief nurse or that clinical director and they're going to go, this is on you.
Yeah.
So there is a real issue in the regulatory system
Yeah.
in order to address this. The other issue we're going to have is the CQC are going to walk in and say you're not observing the patients. Even though the CQC know full well it fundamentally is flawed. So we are dependent on that national guidance to give the assurance to our seniors to be able to make these very big decisions. Because this is a big decision. And if the care on the floor is not at the baseline correct level, and this is where culture of care matters, enhanced care is going to fail quite dramatically. Because we will neither be observing or engaging. And that's a real issue.
Should it not be approved nationally before we have these conversations?
Yep, that's why I said it's all gone to the national programme.
Oh, should we expect?
I don't think so, no. Because you're using an intervention that doesn't work.
But if we aren't able to provide assurance that we're doing what's expected by us and something happens.
You've got research and evidence to help you.
But you're saying the coroner will tear somebody to
Bring
pieces?
your research and evidence with you. What it needs, and this is an uncomfortable position, is bravery.
Yeah. I'm just sitting there thinking that.
It needs very senior people to make brave decisions based on evidence, not just on what we've always done. Because the thing about what we've always done is it doesn't work.
I guess there's a way forward though, isn't there? I'm just sort of sitting here thinking, as a nurse you get taught, as I'm actually, because we've got multiple professionals in the room, we've got social workers, we've got occupational therapists, thank you all so much for coming, dietitians, you name it. I guess we're all taught evidence-based practice, aren't we? And yet weirdly every day we do something that's contrary to that. But that doesn't stop us throwing everything we've got at the evidence-based door. And there's always an option for the thing that doesn't work. But actually, the challenge we should make to ourselves is, if we are evidence-based, like we all claim to be, why aren't we chucking everything at it and then having that? It's a bit like, you can jump out of an aeroplane, but you don't.
Yeah.
You could wrench that door out, positive question all that, but you could. You can jump off a cliff, but you don't. It's the same principle, right?
It is, and we've actually already had precedence of this within mental health, and it's the Use of Force Act.
Yeah.
So, reducing restrictive practice existed for, 12 years before the Mental Health Unit's Use of Force Act got released, and then it was a further 4 years before it got Royal Ascension. And yet, most trusts in 2014-15 were actively working at reducing restrictive practice. So, and why? Because there was an evidence base. There wasn't national guidance, but there was an evidence base. Then the law came out, and before the law we had Mental Health Act Code of Practice. Great. Didn't go far enough, but tried. Then the Mental Health Unit's Use of Force Act came out. And since then, all of the organisations that took evidence base and guidance and when we'll take that under consideration have been forced now to do it. And West London, where I work, is one of those trusts. Because the other thing about guidance, and you will hear this statement, national guidance or not, you will hear this statement, well, guidance is just guidance. We can make a decision not to follow it if we do not think we want to. Trusts take that position all the time. Pull out any nice guidelines. Assess your service against them, and you will see we're predominantly red against those guidelines. So, what we then done is we wanted to train the staff that were engaged in the QI projects, but we kind of realised, why are we going to train people in something that fundamentally we're saying doesn't work? So instead we used that space to develop the model of what should we do instead. And this is where enhanced care came from. And our group was the ward managers and matrons of all of the 10 wards involved, 3 experts by experience, We had a psychiatrist in there, and we had a couple of like lead nurses and stuff like that from around the trust. We all got together, we broke it up into 3 areas, and what we ended up with is a new model to look at. So, what you have is enhanced care, which is an alternative approach to enhanced observations. It's far more collaborative and it's far less intrusive. And it's based off a basic, simple principle. We must assess our patients' needs. Because the problem that we have now got with enhanced observations, it is blanketly applied to all risk. Oh, they're full risk, obs. Oh, they're risk to others, obs. Oh, they're risk to yourself, obs. Oh, they try to go AWOL, obs. Safeguarding, obs. And on and on and on it goes for an intervention that largely doesn't work. And this is the thing about restrictive practices. Its restrictive practices lead to one thing. Does everyone know what it is? More restrictive practice.
Because it's this.
We all know it. It starts with a restraint, then it becomes an RT 10 minutes after that, then 2 hours later they're still going, so we put them on OBS, and then 2 hours after that it was another restraint and seclusion. And then staff get into their unconscious psychology that, oh, but that worked. So then the next patient that presents with extreme distress gets the exact same process. And there's nothing in there to break it up. So, we must assess patients effectively. And by assessment, I mean your whole team. Your medic, your nurses, and the nurses are really important here, because what we discovered was there is a fundamental lack of knowledge in our nursing population on how to conduct a structured assessment, particularly around interventions for risk. And this is where we get back to the issues of engagement, because there is a fundamental lack of skill in our workforce on how to engage, and when to engage, and what to engage the patient with. And if there are patients in the room, I use patient because I've been around a long time. If it's a terminology you don't like, please let me know and I'll use service user instead. So, based on this assessment, and I'll give you a good example, is falls. Who do we get to assess the risk of falls? Do we? When they first, yeah, right. Patient comes in, falls, nurse says, fills out the falls risk assessment and says, oh. And then the physio might see him 3 or 4 days later. And the physio says, here's a set of interventions. But what the physio won't say is, take them off odds. Why? Because they largely see it as an intervention outside of their scope. So who do nurses wait for to make that decision? The medic, absolutely. Is the medic an expert in falls? No, funny enough. Have they ever done OBS? No. And yet this is the person we're asking to make this decision. Why?
Oh, well, our policy says it.
Why?
God knows.
Exactly. Because we do this to consultants all the time. Every decision we don't want to make, we defer to them. And this comes from a lack of confidence and a lack of competence around engagement and assessment skills. And also not using the right people for the right assessments. We've got to get better at it. And this is where part of this model happens. Because what we will ask you in this model is, get the right person to assess the needs you've identified. Don't just throw it at anyone.
I'm hearing all this. Now, I work for nurse.
Yep.
Now, we have been trying to get the staff, because we do have a 1-to-1 and 2-to-1. so long, all different kinds of ways to get them to engage with the patients. The existing policy, which I have read, does say you should engage with people. It gives examples of what you should be doing. We have resources, we have sensory boxes, we've done training. I've put lists of activities outside patient stores that they like to do. Give people suggestions, have gone and kind of taken them by the one-to-one staff, go, can you take him for a coffee? Go get his money. Take him, you know, it's so boring to sit outside a patient store on your phone or whatever.
So let me ask you a question about
Yeah.
who does the ops. Who does the ops?
The support workers in the HCAs.
Great.
Yeah.
Are they autism specialists?
Not all of them. Some
No.
of them have had quite a bit of training,
Training,
or regular
lovely.
staff. We do use a lot of bank staff.
So I was just about to ask a
And we
question.
do try to do dynamic support where we're like, you're new, can I, you know, this is what this person likes. We do all of that as well.
So here's the thing.
Yeah.
80% of our observations are completed by unqualified temporary staff
Yeah.
who do not know the patient.
Okay, so
And just
Yeah.
put it out there, because I think autism is an area we're working towards
I'm just
understanding.
losing my thought. My
Yeah.
thought is the structure of how they're structured, this hourly changeover,
Yeah.
is not fit for purpose for our population. Now, when I'm trying to challenge that and try to introduce a new structure, I'm with management, or you know, it's very binary.
Yeah.
So
And this is where enhanced care matters,
Yeah.
right? Because what you would have under enhanced care is not someone on continuous observation.
yeah,
You would have a daily plan of care, and it might look like an allocation sheet for that patient, right? Where 9 till 10, they're this, 10 to 11, they're this. And there's various things they're going to engage in with that day that they want to, and some of the things that we prescribe. There will be stints in there where maybe that patient or their relatives or someone who has assessed this patient have identified as particularly complex hours for them in the day. Now that might mean, okay, look, their relatives come to see them at 4 o'clock,
Yeah.
they leave at 6.
yeah.
6 till 8 is a very complicated time for this patient. That's when you do the continuous engagement.
So we have, you know, we have a really large MDT in our unit, and we do have some excellent, we have excellent nurses, and we have excellent HCAs actually as well. But in my observation, it is sort of a culture thing.
Oh,
that
yeah.
obs means you just sit outside somebody's room, like
Yeah.
checking on them.
And
And no matter how much we try to encourage support, it comes down to that. So I don't have the authority to say you must do this now. I can, you know, give people advice and try to, but it feels like it's also a culture thing, and it feels like the senior nurses really need to kind of.
100%. The most complicated part of changing enhanced observations. So changing enhanced observations is relatively simple. Don't do that, do this. But in order to do this, you have to change everything. And that is where we are.
Yeah, okay. Yeah.
It is the reality of our mental health inpatient units. I had told you, go look on your ward and see what the general offer of therapies
But it's a
is.
culture, it's not a policy, because the policy in
No.
itself isn't that wrong, like it does tell you,
The
and other
policy-
people do it, we all do it, like I'm leaving here early because I've got to go do a session with someone and it's, you know.
But
Sorry,
yeah,
just
I
from
will.
a time
Yeah.
perspective. Kevin, maybe you'll come back.
Absolutely. But you're absolutely right. It is a culture issue, right? Like restrictive practice, and I have asked the national program board that enhanced observations get measured the same way seclusion of restraint. Because that's the other thing. As you measure enhanced observations, thankfully, kind of reside. We don't do it. Right? Which is the same for most organisations because we don't see it in that way. And until we start seeing it that way, we can't address the culture issue around it. So, you get the gist of enhanced care. I won't go on too much more about it. But what I would say is this. If you are going to place someone on continuous observations within an enhanced care model, there needs to be flexibility within it. You cannot need 24/7 enhanced observations. the reason we do it is because we have not engaged effectively with that person on when they need it. Because some patients will tell you, at this period, if I'm saying I feel like this, I need someone. Fine. Well, it doesn't need to be 24/7. And the other thing about enhanced observations is we place someone on it, and they stay on it for 4, 5, 6, 7 days, 14 days. I went and reviewed a guy on Monday who had been on observation for 67 days. He didn't even need it. He didn't even need it.
Yes.
And the reason he was placed on enhanced obs, no one could even tell me. Because it was so long ago. And this is the problems we get ourselves in. So, finally, training your workforce. And Anissa has disappeared on me. Anissa and myself and a few others were involved in the larger bit of work around this. And, oh, there she is. We're talking about training the workforce, right? And training the workforce, like I said, is not telling people how to do obs effectively. It is training them on how to do engagement effectively and what tools they need to support patients in distress. And that can be things like de-escalation and stuff like that, but it can also be unstructured activity. It can be distraction technique. It can be tip. You can have a rage model. It can be stabilization training. But we need some tools for people because our nursing workforce and particularly our healthcare assistant workforce have no tools. We are asking them to go and do a job with no tools, and it doesn't work. So what we do need to do organisationally is take a look at what should the baseline be in terms of tools and skills you have to work on an inpatient unit. Because for too long, we have treated inpatient services as this broad spectrum catch-all, where there are no specialities within it. And as a result, nurses and HCAs have been diluted in their skill sets. You will hear OTs, psychologists, physios and medics talk to you till dusk till dawn on what their role is and isn't. And everything that their roles isn't, apparently is the nurse's job. How many of you have to do search? How many have to search patients? Where in your job description as a nurse says that you have to be a security guard? And here we are. So we've got to get a little bit more clear about who's doing what. And Katie's looking at me very strongly. So I'm going to move on.
Feel it now.
So, that's it.
That's it.
That's it.
Get on with it, guys.
And I'm sorry it is a little bit rushed. The purpose of today and me coming here was to give you permission to go way beyond what your current policy is saying. Delete the whole goddamn thing and start again. And start with, what should care look like on our ward? And when you do that and you do your culture of care reviews and stuff like that, you will start to write a very different policy. The problem with policy development, and anyone who's worked in it knows, is you get the old policy, you change a few bits in it, you have to reread it about 67 times until you're so dead inside that you never want to see it again, and you just sign it off. And you get this incremental development of a policy that no longer actually represents what you really wanted to do when you first took on that policy review. Because we all take on a policy review with the intention of, I'm going to change this. And honestly, the process just kills you inside until you just go to sign it off, please. And never look at it again.
It's not going to happen to me.
No, no.
You started the conversation.
I know. So, do I have time for a few questions?
You do.
Yeah, so shall we have some questions? Other than, can you please never come back here? Yeah.
Just I'm thinking about the training and support that people need, because when Leda was talking about staff and styles and all, because the staff in question here are like you highlighted, 80% of bank staff that didn't
It's not just the
receive.
bank staff though,
Yeah,
it is permanent staff as well.
Yeah. So 80% of bank staff and what you were highlighting about, the more you increase the number of staff you have on the ward, the more you are likely to have more staff that are not competent to provide the work you want. So I'm just thinking about how do we then switch over to that point where basically the staffing you have is able to provide you with because then it reduces the likelihood of you using bank, and then you have the
So
right staff.
my advice is that under enhanced care, the periods of continuous observation, or what I would like to call continuous engagement, will probably go down significantly. Meaning, your substantive staff who have had a lot of training in this can be the ones to do those stints. Because actually, you'll probably only have 2 or 3 patients on enhanced care, and within it, they'll probably only need 2 or 3 hours within a 24-hour period of actual continuous engagement. So, by working with this model, you bring down that, and what you say to your bank staff that you have on is, I'll take care of the really complicated patient that requires lots of enhanced care and needs, you take care of everyone else. Because actually I know you can do the general offer of care, so I'm going to go and do the really complex care. If you go onto an ICU in a general hospital, they don't give those patients to the untrained workforce. They give it to their specialists and their most trained people, and that's what enhanced care is. It's saying we've identified your level of need as up here, which means the skills of the person to care for you needs to be up here. Go ahead. Pardon?
Okay. So what I didn't hear you say, I think, this is amazing, but what I didn't hear you say is the role of the MDT.
Everyone needs to assess this patient, and that assessment needs to come from your specialist physician. So if the identified needs is falls, it's your physio and your OTs that are making the predominant decision making around what we continue. The consultant and the nurses are going to join in because they'll do medication reviews and stuff, make sure they're not on too many benzos, make sure they're not getting hypertension when they stand, which is important and stuff like that. But predominantly, our assessment is going to be based on what they're telling us. The role of the nurse in all of this will be to take all of those assessments and develop a comprehensive plan. And that is a tough skill. But that is the role that they will take. The role of the healthcare assistants and the nurses as well is then the delivery of that care day to day and ensuring it's delivered effectively.
And simplified as well, because I think part of the problem is actually complicated plans that look very good on paper, but it's actually not translated into practice.
Oh,
So
100%.
Simplifying, yeah.
And what I would say is, for people on enhanced care, their care plan should look like an allocation. It should literally have times of the day, what we're going to do for you and who's going to do it. That's what it should look like. And somewhere in there should be reviews, the assessments you need, and then and you can have moments like going out with relatives between 2 and 4, fine. If that's what's going to help them with their care, great.
I have two strands of thoughts going through my mind. One is culture change takes a long time. And I do wonder about job descriptions and descriptions of what your role will actually entail, and whether we're honest with people about all of these different that they would be expected to engage with somebody. So I'm working in acute services who is extremely unwell, potentially aggressive, it's actually very, very difficult to do. And I think we need to think, the second strand is thinking about the trauma of the staff doing that work and how we support people with that. So I think it sounds lovely to say you should engage with people and not observe them. But I always say this to senior staff, go and do an hour of bolts on a PQ and then have opinions about what should be done, because there's a reality to the human experience of being there. I don't do ops, I'm a psychologist, but I feel the pain of the HCAs who do that.
So what I would say is, I'm
One more thing.
Yeah, of course.
So there's something about training, job descriptions and induction.
Yeah.
And if you want to change culture, the new staff who come in have to see how it's done differently. You can't just tell people do it differently. They have to see the people already there doing it differently, and then it becomes a culture. So you come in and you say, oh, this is how it's done here.
So, at the beginning of the presentation,
I was told to come to
no, at the beginning of the presentation, we spoke about this and about how there is no national definition of therapeutic. We don't tell people what the expectation is. We have no systems in place to readily deliver this, and there's no tools.
A trust can have a view, can't they?
And that was what I said. Is that this is about organisational accountability for what we expect our staff to do.
From the top.
For 100%. Now, I'm the restricted practice lead where I work. I still do ops. And I predominantly do them on PQ. And I predominantly do them when I'm terminating seclusion. So that real high risk period. Because I completely understand where you're coming from. And if supervision, and are there nurses in the room?
Yeah.
Okay, great. What clinical supervision do you get?
4 to 6 weeks, once in the 4 to 6 weeks, and it is management and clinical supervision
so
most of the time together.
Management. Managerial supervision. You're a psychologist. What's your clinical supervision look like?
Well, mine is about once in 3 months, but that.
What does it normally look like?
If you're, band 7, you would have it every week, 1 hour a week.
1 hour a week, guaranteed, mixed in with managerial?
Yes.
But predominantly focused on clinic. And do you have a model for your supervision?
Different people will do different things, but yeah.
Do you have a model?
He had a very long list of
And here and here is the problem where it starts, right? We are not supporting nurses and HCAs. We are not helping them with the trauma of the work they do. And that isn't just the abuse and potential violence they face, it's the vicarious trauma they experience as well. Watching someone cut themselves really badly or cutting ligatures off them is traumatizing. Our workforce is largely completely naive to the trauma they are experiencing. And our well-being services need to be pumped up about 500%. And I done this in Camden, where if you were assaulted or you were part of witnessing an assault on the staff, it would automatically trigger a referral to the wellbeing services, right? Now, which was great, right? Oh, brilliant, everyone gets the wellbeing. 3 weeks later, I sat in a meeting with the head of the wellbeing service, who was a counsellor, and she was crying, saying my referrals have gone up 3,000% with all these traumatised workforce, and I don't know what to do. So be careful what you ask for sometimes. But it was a reflection of where we are as an organisation. And what I would say is, I 100% agree. But we've got to identify that.
I'm really sorry, I'm really mindful of the time. This is a great chat. This is our first event as part of the policy review. So if anything, it's an indication that we've got a lot more that we need to do and we need to talk about. We were going to have Johnson with us, who were part of the pilot work that Kevin did, but they have had to do something else, which is fine. We have got Anya with us, who is leading on zonal observations in the trust. So again, a different way of providing care, what that looks like. Anya, I'm literally looking at 3-4 minutes max. Whistle stop. Slides will be circulated. Thank you. Thank you.
Okay. Doesn't have to be filling my pulse. Yeah. Thank you.
Thank you.
Yeah, hi. So just here to previously and what Kevin done, but just thinking about what as a trust we are looking at, and thinking about other ways of working. And zonal observation, it was actually a few days ago until recently. We just changed it to zonal enhanced care, or thinking about it in a different way. So I'm glad when I saw that, I was thinking naturally I would have been holding it from the start. But yeah, so zonal enhanced care, and we are looking at that currently, so the current situation, so what we have in the trust at the moment is a situation where enhanced observation, where 1-to-1s or 2-to-1s, as highlighted earlier, and then totally restricted because then you're pulling people around. And then in terms of cost as well, thinking about it in that sense, you end up increasing and increasing numbers without actually adding or reducing the risk that is there. So risk of high numbers, so I highlighted this earlier where you increase, as soon as you're going up and up, then you've gone above your super staffing numbers, usual one, meaning that you then have unfortunately get access to SLTP and some of the training that we know. So that increases the likelihood of you having the right staff to be able to support. So initially, so what zonal observation or zonal enhanced care is where you look at the ward and then divide the ward into zones and then think about how many staff do you need to be able to support that. So you have presence anywhere you go and be able to provide any kind of engagement that is needed. So that does mean that you don't have patients who are then kind of distressed out because they don't have anybody to engage with, they don't have anybody to support them. And then it gives you assurance as well that staff are not moving from one place to the other where there is nobody to support the patients on the ward. So staff member is assigned to a particular zone, and within that as well, there is the way the zones are divided, you have people being able to keep line of sight among each other for the staff that will be in the zone. So the expectation is that if you have that, then there is less likelihood of you needing to put people on enhanced observation. One of the reasons being that there is presence everywhere. So there is people to engage them even if it's observation, but then there are people who then get involved in the communication or engagement that is needed for those particular zones. And in most cases, you end up having 2 to 3 zones within the wards, and that provides that visibility that is needed. So benefit of zonal enhanced care, less intrusive, enhanced privacy and dignity, so you don't need to be you'll be present but not necessarily. So there are areas as well which I will get to where you might have to put someone in an enhanced observation depending on what's kept increasing enhanced observation the results itself and all. But better patient engagement and effective risk assessment. So in terms of journey so far, so so there has been discussions around the need to change the way we do our enhanced observations or the way we use observations within trust. And there was an APICI conference that was done, a presentation from other trusts, how they have managed to do other things. So we managed to work with them initially to find out what they've done. So now and KMP currently using zonal enhanced observation. So we've been liaising with them, got them to do some presentation with our PQs and us as well, thinking about how that works. Currently, we are looking at it for our PQ wards first, so that it gives us an idea of how that could work, and then we'll think about how we'll be able to spread it across the trust. Then we looked at who would be involved in this work. So we've been meeting weekly and recently every other week. So we had to put together a working group. Katie is part of us actually. Sarah, this is Sarah, who is also in our group, one of our patients who is doing a great job in terms of using the experience from previous nations to kind of be able to support that. Then we have PQ matrons, PQ staff who work with the wards, just working with us over the past few weeks to make sure that we are getting it right. Initially, we looked at a different model where we have to get to a number of 8 to be able to have enough presence on the ward before. So that means that we would wait until there is first enhanced observation, second enhanced observation, and then third one. Then the 3 people, we can then review and decide that the 3 would go off ops, and then we use zonal enhanced care instead of that. So
There you go. I'm used to.
So I've been talking to myself just a bit.
And everyone here is listening.
Not to listen that, but I will need people.
Oh yeah, not for that long. You've been talking to yourself, but not for that long.
Thank you for the reassurance, Saeed. That's helpful. Thank you to know that. So Saeed also is one of the people working with us in terms of the zonal observation. So zonal enhanced care. And so over the past few few months, what we have realized is that because of a lot of work being done by Lisa and everybody else, there has been reduction in terms of use of observation level. That means that getting to that number, that 8 as a start, we rarely saw that. So we're two of our awards, 2 of our PQ awards in the past 4 months that we've been doing it. So we need to review that. So in our last meeting on Tuesday, we then discussed that, or 2 weeks ago, we discussed about the fact that we need to maybe consider our normal numbers, which is staff, nursing staff within the wards. So thinking about how do we utilize zonal observation as a on a baseline number that we have on the wards. So we felt that having 3 people out of that seat is a lot. So we considered how we're able to divide the zones into 2 zones, so that we have, in most of our PQs, majority of them will be classically 2 zones, but then there will be kind of lounge area that might be a bit segregated. So we're thinking about how we'll be able to do that. So we then worked with the team, thought about which teams are able to. So at the moment we are then using Johnson Uni. So Johnson Uni I need to do the piloting for this over the next few months. So over the next few months, then we'll do a review and then see what the work that they have done.
Sorry. Okay.
So at the moment, so like I highlighted, Johnson is piloting that. So over the next couple of weeks, we will then meet again in 2 weeks' time to think about what has the pilot told us, what are we going to be doing at the moment.
I was just going to add in, we're thinking about how we blend that in, and then also co-designing the protocol. We've drafted the protocol, but actually it's really important to start are actually developing that protocol, because to then sort of test out in other areas. So we're just going to have to.
So can I just ask a clarifying question? Is this zonal observation or is that a zonal care?
So the name itself, in our last meeting, we said that we don't want to use observation.
So
zonal observation.
It's a care delivered in a zonal.
And that's the transition.
So this actually. The PowerPoint that I presented here it was zonal observation, it was. But following our meeting on Tuesday, I then reviewed that and took that off. So the zonal care we have, or zonal enhanced care, we haven't actually agreed on a name. So, but I didn't want the observation to be there. When I'm presenting it here. So we agreed that when we meet in 2 weeks' time, we'll then, some people highlighted, some people said zonal therapeutic care, zonal therapeutic engagement. So the people say co-pilot, we had a few names.
A nice new acronym.
We love an acronym.
You want to work backwards from something.
How did you get to that decision
to remove the
observation?
It's quite scary.
I was sitting here getting a look.
So over the past, I think it's just been coming in terms of the name itself. So when I did the 1-page protocol for the within that, I think we have mentioned it before as well, but I sent an email saying actually, I think we're going to be thinking about the name and how we will do it. So that was last week, and then we did this meeting. Have I done mute again?
Can you hear online? Margaret's saying no.
Yeah. Oh yeah, we are fine. You're fine.
Thank you so much.
So for me, I think it's just reflective of where we are and where the conversation is at. So I think it's just.
So we've been discussing it, but then in that protocol, then we reviewed that, and then last meeting we agreed that we haven't agreed on in the name yet, but we are not going with the observation. And then we would agree on that in 2 weeks' time. So in 2 weeks' time, we'll then make a decision on the name, but I didn't want observation to be there.
And we're blending in the unstructured activities.
Yeah, the unstructured activities. I just want to actually thank the PQ teams in terms of their bravery around this, because when we're talking about bravery and how we increase obs just to for our own benefit to an extent, as well as just for patients. But then Johnson, all the PQ teams have actually been very proactive in supporting this.
So, two comments. One is about zonal observation or care.
Yeah.
Not allowed to use off, the word's banned.
I'm very happy about that. I'm very happy about that. Whether that is part of our actual offer rather than, when observation.
So that's what we are.
Yeah.
That's what we are.
Yeah, no, I'm really glad, and I really hope that these zones are not around health and safety, because some of the wards have zonal things, but it is because there are ligature and therefore you have to be there, and we find staff stuck in a room whether there is a patient
There's
or
no
not.
one.
They're just sitting there. So sometimes that happens. Yeah. So that is really helpful. I even want to go with general ops, and I absolutely do not like this general ops, which is one hourly, but it actually becomes head count, and I absolutely hate that. That we are not in prisons and we are not doing head counts and things, because that needs to be also an intervention or engagement rather than, because we have had. And I was talking to Helen the other day, we had incidents when staff are doing check, when patient is sitting in a situation where it's very obvious they need help, but the staff felt that they are just doing check. So they checked and then they left. and that kills the purpose of why you are even going there.
Yeah. I think over the past, what I would say is that this, and thanks to Katie and a lot of people within, because over the past few months, we have kind of moved on as we reviews, and the teams will come back with feedback, and then we have a PTSA kind of sheet that is completed, what has worked, what hasn't worked, and that's how we have kind of paused the 8 and then decided we'll go with the baseline number. So at the moment, fingers crossed, we will get, even if we don't end it at 6, the point is that we get to a position where, as a trust, we have a different way of working around us together.
It's really interesting. We have a meeting planned for a couple of weeks' time, and we are looking at allocations as a whole, as to how do we do zonal care. So when we are doing allocation, how do we work around that people's presence, and I call it vigilant. It's a vigilance everywhere, not only for some patients, it's vigilant. If we are able to provide vigilant care, we would not need these top-ups. And it's interesting, one of my services has a history of a very long, 6 months. And what we have been sort of talking about is enhanced care plan rather than enhanced observation. And it is a real difficult transition because teams are not always on the same page.
I would say, and I forgot your name. Tamara touched on this though. You've got to think about the trauma of your work, right? Because actually what happens is an event happens that traumatises them, and their natural inclination is to retreat. And that retreat is the office or bringing themselves down to a task-based role. And that's why you need the supervision, the wellbeing services, and all of these things there, reflective practice, to get them back out.
We can carry on the conversation, but yes, do you want to final word?
Back to culture and senior. I've just checked my phone to be told that reflective practice has happened again because nursing staff, the acuity was too high and they couldn't come off. So if we don't support staff to take that time, everybody says they want it, we provide it, but then nursing staff and HR actually physically cannot get off the floor to go and have that time. What are we doing as an organisation? It's a lip service. It's a lip service and it's a waste of everyone's time. Sorry.
That's the right one, thank you. Andre, final word on
No, I was just going to say that it was really helpful. It's been helpful in terms of the teams and talking about the people that we've been working with around this. Because the staff within that group or the senior staff within that group are positive to make this change. And that's why those conversations we kind of continue to review. So I'm co-leading with Machi here, what is on leave at that moment. But then the matrons, the team leaders and everyone being really proactive in terms of wanting this change to happen. So I just want to highlight that.
No, huge shout out. People being ready and embracing change is so important, and people being ready. So thank you, Andre. Thank you. Really mindful of the time, the thing that I really felt like it would be important for us to cover is we want to carry on the conversation. There are 8 areas we've identified in the policy. I just want to spend the next 7 minutes just quickly talking everybody through them, because then I'll leave the chat open. I will pop all of this into the chat as well. We can carry on getting people's feedback, and again, like we said, this is the first of many events because we need to get it right. But I just wanted to talk through, just in case there's any clarifying questions, in terms of those 8 statements, and just for people to take it back to their areas, if that's okay. Yeah, so whistle stop talk. So, as we have discussed, one of the main highlights is no more observation. It's all about engagement. Our current policy is observation and engagement, but it's just how do we bring that engagement word to the forefront and less of the observation. So like Anya touched on, like Kevin touched on, it's really about change in language. But as Tamara said, change takes time. How do we work on this together and tackle the word observation?
So Anissa, clarifying.
Yeah.
This is the question we are seeking consultation on.
That is correct.
Until the new policy comes in place, the current policy is valid, and we need to start thinking about how we do engagement element a bit better. Because that's a really important one. When we are talking about banning observation, I totally agree. We ban the observation, but we can't leave the vacant. We can't leave the vacuum.
Yeah, no. I think that it's in the nuance, isn't it?
Yeah.
The word observation is banned. But these are questions, not instructions for now. Yeah,
it's what we want to think about. And actually, those of you in the room, you'll have time afterwards, diaries allowing, to go around and put your thoughts on post-its. And actually, we've had some feedback on why the consultation should stay today. That's why it definitely is consultation, and we'll weigh it up and see what we can do. Next one is tell us how to spend the time we spend with you. So this is more to our service users and patients as well as the nurses providing care. So we're talking about what does engagement look like. Not everybody wants to engage. How do we meet the needs of the individual? So I currently work in CAMS. We have young people who don't actually want to talk all the time. They don't want to engage. They've been fantastic in coming down and offering some views. So just for the different areas that we serve, let's try and find out what does engagement look like for them.
And I think that's where things like a lack of standardised definitions about therapy because actually it's a range of things. You know, I've sat with a patient in the ED unit for 5 hours and we've not said a word. But I was engaging with them, I was present. I wasn't observing them, we done little things together, but they didn't want to talk, they weren't in a place to talk. That's fine. They felt
Yeah. And having did a project on a sort of performer, what matters to me. And it's how do we get those nuggets of what people have been working on within their teams, within the directors to bring it together. So as she was leaving, I was saying we need to think about how we sort of scale up or spread, because it is, it's for older adults, but it's all about if I'm distressed, this is what helps me, working with the families, all the things we're talking about. So how do we pull what's out there, the good practice and that people are doing, that we can think about how to improve it.
Absolutely. That's going to be our next event, actually.
Yeah,
that's a good place to start.
Yeah, and I'm thinking about the staff providing that care as well. I'm a bank staff, I've just come on, I don't know the patient group, what can I do? And another change idea we had at the same time as Paddy's one was in CAMS, we did one thing, and that was, what's one thing? If there was one thing you wanted the person to know about you, what is it? So it's just how do we, multidisciplinary teams can stop and reduce observation. This one. Our policy right now says only the RC, responsible clinician for the patient, can step down or reduce any observations, or they can delegate the responsibility to an on-call medic. how can we change this?
MDT.
Are there any medics in the room? No. No,
So I've spoken to the medics, they know we're coming.
That's it, they know we're coming, that's the main thing. So big one, this is a big one that we really need to, because right now, out of hours, weekends, nights, nobody's observations get reduced. Shouldn't be that way. Next one is, tell us the best way to review patient need for enhanced engagement. In our policy right now, it states that enhanced observations should be reviewed every single shift and documented. Does that happen? No. Should it be that way? Does it need to be every shift? Does it need to be twice a day, once a day? How do we do it? Where do we document it? What systems do we currently have in place? We have ward rounds, handovers, safety huddles. Can we capture this there? Why do we invent the wheel? Where do we document it? These are the things that we just need to, the lens that I want us to have is how do we make the policy work for everybody, and what's on paper is what happens in practice. Student nurses. Controversial, there's been lots of debate about this. As per our policy right now, student nurses are not allowed to undertake any enhanced observations. My point of view, from many different people we've spoken to, how do we support our upcoming cohort of staff? Student nurses can support in providing care, they can support in giving medication, they work under the supervision of our registered nurses. What is different about enhanced observations or enhanced care, as we will be calling it?
What's the MA's position on that?
So I spoke to Elisa. They're putting together a framework to support workers and upcoming nurses, student nurses. So Martin has been running a pilot in Lambeth on 2 wards. A lot of the universities are happy for students to work in accordance with trust policies. So it's our policy that says no. Some of our neighbouring trusts, so Oxley's, their policy says yes, so students do undertake observations in their organisation.
As far as they are competent, there is no reason for...
Absolutely.
How do you know they're competent?
Well, we have again, that goes back to the trust policy. How is the support worker competent? We do the competency assessment, and that is where they become competent. So.
But if we're saying one of our skilled workers, if you're still learning, it's throwing you another deep end, isn't it?
But with support worker, we do throw them in the event.
So if we capture this on a post-it note, that would be lovely. Yeah. Sorry, it's just because it's 1 minute past 3,
it's fine.
and I know everyone's really busy, and so grateful for everybody dedicating their
And
time.
just on that, the student would go to a bank shift elsewhere, and be on a nursing.
It's a good point. I'm glad we allowed you that time. Next up, we have, tell us the best way for shift coordinators to ensure unstructured activities happen. So we want it to happen, but how do we capture it? So there's something about allocation sheets, having standardised allocation sheets across our trust. It's a big trust, lots of areas do different things. How do we capture it? What does it look like? Should it be on the allocation sheet or not? And if anybody's seen, examples of good practice in other places, how do we, incorporate it here?
Pinch with pride.
Pinch with pride. I couldn't think of it. Thank you. Next one is, as we were talking about, we have a blanket rule, either said or spoken or unspoken, in the different areas around people being popped on to enhanced jobs because of they're pregnant or any safeguarding issues. How do we tackle this differently? How can we be creative? What does enhanced care, what is the need here? How do we, so we need to capture that. And then last, but by no means least, training. Kevin spoke about it, we've spoken about it a lot. What does training look like? We've had lots of ideas from the people who have dropped in this morning, people talking about simulation, e-learning, talking through different activities. So right now the competency is, I think, 2 pages. You read through it and then somebody undertakes the competency, and we actually had a discussion about who is signing off the competency as well. You know, how do people feel confident and comfortable in providing care?
You've all had a newly qualified nurse where you go, who signed this?
Yeah.
And it wasn't that person that signed them off was a bad nurse. It's the pressure the system causes and puts them in a position where they could have not signed them off, even though they may have thought, I don't want to.
So, what's next? What's the commitment? What are we asking for? Like I said, there's going to be ongoing events. We need to move forward together. We're going to do the policy launch in April, so we've got some time to really commit to this, bring about the changes that we want to, and how we can do it together. And the role of our SUCAGs is really important, so that's the next stage. We've had some patient involvement today, which we're really grateful for, but we need to, again, the people receiving the care and giving the care, and how we can work on it together.
Excuse me.
Anything? Yes, lovely.
I'm nothing to do with the scenario at all, so tell me if I'm not allowed to make an intervention.
Please do.
I think what you've done is amazing, but as an outsider, a non-professional, I am a professional, but not in your profession, personalising your intervention is important.
Absolutely.
So it means it's relevant to the individual.
Absolutely, yeah. Individualised care, we talk about it. Individualised care, we talk about it all the time.
Oh, sorry, I didn't. I'm not.
No, but how do we deliver it? You're
I don't
right.
know anything. I've only been here for about 15 minutes. But personalised, it makes it individual for that person, and that's so much more. It causes much better currency.
Absolutely. Thank you.
Thank you so much.
Yeah, no, thank you. Helen.
So just to say that the decision makers are in the room today. So if you want to be part of the decisions around the change or the next phase of change, recognising that culture and strategy and all of that, can you just write your email, because we'll specifically invite you to some of the decision-making points, because there will be some around the policy, and we're really keen for the multi-professional involvement. We really welcome it, so please do let us know if you want direct communication. And then we will be publishing this. Basically, the ambition is to do an event every month as a minimum, which we'll kind of promote in the same way we did this, but maybe get better at it, because we did a quick spin on this.
We did, yeah.
And then before we close, I just want to say the biggest thank you to Kevin. Thank you so much. I'm so inspired. I wanted to stand up and shout "Vive la revolution," and I may, yeah. I want to say a massive thank you to Anita and Katie, who have actually been at this work for 2 years now with the improvement huddle that nursing has been involved in. I want to say an even bigger thank you to everybody that's taken the time to come and be part of the conversation today. It's the start, not the end, and I really, really appreciate you coming. So I look forward to seeing you at the next event. So yeah, Vive la revolution!
Thanks so much, everybody.
Please leave your ideas.
Yeah, please do. I'll just put this on the table here.
Mental health is finally getting the attention it deserves. For too long, it's been shrouded in stigma and misunderstanding, but things are changing. The NHS, the UK's public healthcare system, is stepping up its game with a renewed focus on mental well-being. At the heart of this transformation is a commitment to enhanced engagement and zonal care within inpatient mental health units. What does this mean? It means creating a more compassionate and effective system of care. Enhanced engagement is about truly connecting with patients. It's about listening to their unique needs and experiences. It's about empowering them to take an active role in their recovery. Zonal care takes this a step further by dividing inpatient units into distinct zones, each tailored to a specific stage of recovery. This allows staff to provide more focused and personalised support. Imagine a place where you feel heard, understood and respected, even during your darkest moments. This is the vision behind enhanced engagement and zonal care. The NHS 10-year plan launched in 2019, is a testament to this commitment. It outlines a bold vision for the future of healthcare in the UK, with mental health as a top priority. The plan recognises that mental health is just as important as physical health and deserves equal attention and resources. One of the key aspects of the plan is investing in early intervention and prevention programmes. By addressing mental health issues early on, we can prevent them from escalating into more serious problems that require hospitalisation. The plan also emphasises the importance of providing a wider range of services, including talking therapies, crisis support, and employment support. This holistic approach recognises that mental health is complex and multifaceted. The NHS 10-year plan is a game-changer for mental health care in the UK. It's a clear signal that the government is serious about tackling this critical issue and improving the lives of millions of people. One of the most striking disparities in mental health exists between men and women. Men are less likely to seek help for mental health problems, and they are more likely to die by suicide. This is a complex issue with roots in societal expectations, cultural norms, and access to services. Zonal care offers a unique opportunity to address this disparity. By creating zones specifically designed for men, we can create a more welcoming and supportive environment for them to seek help. These zones can be staffed by male mental health professionals who understand the unique challenges that men face. They can also offer therapies and activities that are tailored to men's interests and needs. In addition to gender-specific zones, zonal care can also address other disparities in mental health, such as those related to ethnicity, sexual orientation, and age. By creating a more inclusive and equitable system of care, we can ensure that everyone has the opportunity to recover and thrive. The success of enhanced engagement and zonal care hinges on collaboration. It requires a concerted effort from healthcare professionals, patients, families, and communities. Stakeholder engagement is paramount. The NHS is actively involving patients and families in the design and implementation of these new strategies. They are gathering feedback, listening to concerns, and incorporating lived experiences into the decision-making process. This collaborative approach is essential for ensuring that the new strategies are effective and meet the needs of those they are designed to serve. By working together, we can break down the stigma surrounding mental health, create more compassionate and effective services, and support people on their journey to recovery. The NHS's new mental health strategy is a significant step in the right direction. It's time to embrace these changes and create a brighter future for mental health.
I'm going to let this keep running so then people can pop any comments in. If you'd like to say anything, please do.
It's working.
And if the fates should
Perhaps we're looking
bless
for one of a kind, the cultural exhibitions around the world, all traveled and places. Stay tuned to my channel, KB Jojo Newsbox, where I intend to give you every vital information, updates, interesting places, places of interest, tourism, and about people, culture around the world. Stay tuned on this channel. We promise to give you more. It's guys. Thank you.
And if the fates should bless us with a moment of reprieve, we all could stand together in the silence and just breathe. Rejoice for all the happiness